Okay, hi Dr. Kanika. Good afternoon to you. I think we are live.
Good afternoon, Dr. Saurabh.
Yep. Hope you are doing good and your family members are fine amidst this corona pandemic which we had and we are passing through.
Yes, fortunately, all are failing well. I think self-discipline has been the key. That is what we endorse to everyone.
Good. So today we just wanted to go through a topic which is quite important in patients who have cancer and specifically related to the treatment as a side effect or as I should say outcome of cancers in some patients, and that is related to thrombocytopenia, what it is, and how we do we manage it. So before we go ahead, I would request if you can just provide a brief introduction about yourself, a background, before we go ahead with discussions.
Yeah, so I'm Dr. Kanika Sood Sharma. I'm a radiation oncologist by my profession and trained in radiation in the initial years. Medical and radiation elements of oncology have been the part of my training. But ever since the completion of training, I think it is the radiation which has been primarily the domain of my practice. But since now oncology is multimodality, so we all are sailing on the same boat. So topics like this are of importance to all of us. Currently, I'm director and clinical lead in radiation oncology at Dharamshila Narayana Superspeciality Hospital at Delhi.
Great, great, Dr. Kanika. So good to have a expert with us to provide insights related to the management of the situation. So before we start with the management, can you just provide a brief definition of the thrombocytopenia? I mean, what exactly it is and how we diagnose it. So if we can start with the definition.
So see, as the name itself indicates, thrombocyte is the platelet in our medical terminology, and penia indicates a decrease. So a decrease in platelet count is called thrombocytopenia. And by virtue of the levels, the lab levels, any platelet level which is below 1.5 lakhs would qualify to be called as thrombocytopenia.
Right. And so this is more of a medical side, but what are the implications of having this thrombocytopenia for a patient? What exactly happens to the patient, or what the risk that comes up with patients having a thrombocytopenia?
So I think a general perception is when there are low platelets, everyone always thinks that the only fear is the fear of bleeding. But in oncology, the impact of thrombocytopenia is very far-fetched. So first of all, we very well understand that if the levels are below 10,000, there will be a risk of bleed, especially tumors which are in brain. They are vascular tumors. They can start to bleed. There may be brain metastasis. When the platelets go down, they may start to bleed. There may be some other vascular tumors, bronchogenic tumors, which may start to bleed. Second thing is whenever you're contemplating treatment, for example, a patient has to undergo surgery and the platelet counts are less than 50,000. Such patient will be at a higher risk of bleed during invasive procedures. If I talk of my field, a patient has to go for brachytherapy. And if the platelet levels are below 50,000, the patient will torrentially bleed. So you will not be able to perform this particular procedure. If the levels are above 50,000 but still hang on below 1 lakh, still we need to modify our treatments because our treatment itself also entails the risk of thrombocytopenia. So our treatment intent, unless if it is radical, there are gaps introduced because of thrombocytopenia, or we might have to reduce the dosages of our drugs or treatment to overcome thrombocytopenia. That impacts the treatment outcome. Because as and when there are gaps introduced in treatment, overall treatment times increase, which has an impact on survival also. So thrombocytopenia is just not the bleeding risk. There is a risk of the stoppage of treatment, delay of treatment, and even prolongation of treatment time. So it is a far-fetched loss which patients do encounter if they have a very, very intense level of thrombocytopenia lasting for a longer duration.
That's quite a serious impact for specifically for the oncology patients. So what kind of awareness exists for such kind of a condition amongst the patients? And I mean, are there any, I would say, signs that the patients can look at to be sure that they identify early on when they are on treatment?
So to be frank, patients are unaware of this condition till the time they actually come to the clinic for treatment. It is very rare that if somebody has gone for an annual checkup or has been investigated for any bleeding disorders, that you would know that it's a pre-existing condition. I'm not talking of oncology, but per se, most patients would either have some bleeding diathesis. They'll be bleeding from the nose. There'll be purpura, blue or red patches over the body, bleeding from the rectum. So such disorders preempt the person to reach the doctor, who on investigation then finds out. When I talk of oncology patients by and large, it is by the virtue of the fact that we screen them so regularly. Most of the patients are going for blood investigations prior to commencement of each chemotherapy, or those patients who are ongoing radiation, there'll be weekly blood parameters done. So they incidentally are noted. But many a times, there may be sudden dips when patient comes to us with sudden epistaxis, bleeding from the nose. And these are alarming signs. If there is active bleeding, actually, that is the time it's like an emergent situation. But most patients are unaware of thrombocytopenia. It doesn't give any marked signs and symptoms apart from bleeding.
Okay. So quite a hidden kind of a condition for the patients, right? Till the time they develop some kind of a complication or kind of a bleeding, right? And
Absolutely.
what's the cause of this thrombocytopenia? Is it because of the treatment, or is it underlying disease? I mean, what's the major cause for this kind of a condition to happen specifically in oncology patients?
So see, as we understand, why should the level of a particular cell go down? Either there is something which is not allowing a good amount of production, or there is something which is destroying it and it is dying early. So majorly, there will be a decreased production when there are certain tumors which are affecting the bone marrow, because bone marrow is a factory for production of all the hematopoietic cells. So our stem cell is in the bone marrow. So there may be tumors like lymphomas, leukemias, which are suppressing the formation of the blood cells. Many times, bone metastasis, secondary deposit from breast cancer or stomach cancer or even prostate many times can suppress the formation of blood cells. Then there may be the impact of our treatment. Like if we are giving radiation, particularly so in the pelvis, where 50% of our bone marrow resides, then by the myelotoxic effect of the treatment, that is the radiation itself, the cells are not being formed. Then there may be certain drugs, like if you talk of gemcitabine, for example, and then you talk of etoposide or bortezomib, they tend to decrease thrombocytes. Bortezomib, it does not allow the megakaryocytes to develop into a platelet. Etoposide, it decreases the programmed cell death time of platelet. If a platelet was to live for 3 days, it abbreviates its life. So it is reducing or increasing the chance of apoptosis. Gemcitabine, again, cyclophosphamide, busulfan, all these drugs at different levels of cellular maturation of platelets interfere with their formation. Then next is cytotoxicity itself, because cytotoxic drugs, when they impact the cancer cells, they also impact the growing cells. So myelotoxicity it itself induces the thrombocytopenia. Apart from the oncological aspect, you see our patients are challenged with many more things. Cancer patients are at risk of infections. Infections again predispose to thrombocytopenia because there is a larger consumption of platelets. For example, a patient develops DIC. Most of the patients, the DIC will consume all the platelets, leading to thrombocytopenia. A similar situation of decreased platelet but DIC occurs in two particular cancers called CA pancreas and CA stomach, where there is this bleeding tendency because DIC is a systemic effect of these two tumors. So I would say it is not one single cause. It is a multifactorial array of causes which contribute towards the development of thrombocytopenia. So etiopathogenesis is complex and very, very diverse.
So is there do you have some ways to actually say whether thrombocytopenia is because of the drug, is it, or due to some underlying disease like you mentioned, or because of this side effects? So do we differentiate it, and does the progress of such kind of a condition differs by the cause of it?
So see, there is no one such test. The first test, I think, whenever we conduct is a complete blood count, which would indicate there are low platelets. But a simple CBC would not be the final say. we usually get a peripheral smear done, because many a times the CBC, these are quilter reports. They do not count the large platelets or the megakaryocytes. So first of all, you need to confirm. Then it's a diagnosis of exclusion. So by history, you try to exclude what can be the cause of thrombocytopenia. For example, my patient has had a vaccination, has had some viral disease previously. Patient has a liver disease. If patient is a CLD patient, then thrombopoietin is not secreted in the body. Patient has hypersplenism, spleen is eating away more platelets. Or what is the drug patient has used? And in our country particularly, I think most oncologists would also ask, are you taking Ayurvedic or any alternative medication? Because though how much innocent these other alternative medications may appear, they have myelotoxic effects. Most patients who have been consuming years of alternative medicines, they tend to have their platelets ranging between 80 to 90,000. So it is a diagnosis of exclusion. So once you exclude all causes, including ITP, then you establish that this particular is a chemotherapy-induced thrombocytopenia, or a radiation-induced cytopenia, or a disease-induced cytopenia. So it's primarily a diagnosis of exclusion.
Oh, okay, that's good to know. And do you have any kind of a grading system for this? I know, I mean, being a medic myself, there are a lot of grading system exist for different conditions. So do we have a grading system for thrombocytopenia also?
So in generalization, if I talk, if we're talking of non-oncological settings, we usually call it mild, moderate, and severe. And severity is defined by its value. So any platelet which is less than 50,000 would be a severe, 50 to 1 lakh would be moderate, and 1 to 1.5 would be mild. But again, having said that, this severity also depends on the disease. For an ITP patient, 50,000 would not be severe. For ITP patient, it is the 30,000 which would call us severe. But I know you, since you are from the oncology background, we tend to use the CTC criteria. So in oncology, as per the CTC criteria, it would be graded grade 1, 2, 3, 4. And as the grade progresses, it indicates the highest severity. So grade 4 would be platelets less than 25,000, 3 would be 25 to 50, 2 would be 50 to lakh, and 1 would be from 1 lakh to 1.5 lakh. So it is the grade on which we take a call in terms of our treatment intensity changes also. That is the importance of grade. Apart from finding out who would require a transfusion, it also helps us to decide that in our subsequent chemotherapy regimen, how much dose reduction do we want to do. That would be dictated by the grades of thrombocytopenia.
Right. So apart from the decrease in the dosages, does the severity of thrombocytopenia impacts any other aspects of management of cancer patients?
Yes, see, if a patient is having thrombocytopenia, your bleeding tendency is higher. So if patient is to go for a surgery, or for example, patient is planned for any procedure which is invasive, the chances of bleed are higher. So you might have to either wait for that procedure to be done, or build up the platelet levels to a safe range to go for that procedure. Second, you might have to change the choice of drug per se. For example, if I talk of maybe head and neck cancers or pelvic cancers, we have 2 platinum drugs which can be used as radiation sensitizers. We have cisplatin, we have carboplatin. So carboplatin tends to cause more thrombocytopenia. So our choice of drug would also change in a patient who has tendency for thrombocytopenia. If we have an efficacious drug, we would prefer to use the one which causes less thrombocytopenia. So it is a decision maker also in terms of choice of treatment.
Right. Okay. And I'm sure it would have an impact then on the outcome of
absolutely
also, right? Because if I'm changing a drug, it will impact the outcome of the right. Fine. And what's the usual?
I'm unable to. Yeah, your voice.
Patients that each patients have a thrombocytopenia.
Can you repeat? I'm losing your voice. Can you repeat the question? I somehow lost the voice in between.
And specifically the oncology patients, I mean,
yeah,
who have this kind of.
So
I'll repeat again, Dr. Kanika. What I
yeah,
mean was,
yes,
how do we treat?
okay.
Can you hear me?
Yes, so I believe you have asked me the treatment for
Can you
thrombocytopenia
hear me
and
now?
oncology. Yes, I can hear you. So, talking of treatment, see, the treatment again is dependent on the degree of thrombocytopenia.
Can you hear
Hello, Dr. Saurabh?
me? Can you hear me now?
Yes, yes, please.
Okay.
Will you repeat the question? I believe you asked me the
Yeah.
treatment. Am I right? Yeah. So, as I told you, the treatment would be dictated
Yes.
on the degree
Yes,
of
Dr. Kanika.
thrombocytopenia, first of all. Secondly, we would also want to know what is our intent of treatment, whether it's a palliative treatment, it's a radical treatment, because the choice of drugs which you will employ in the treatment will be determined by that. So first thing when you are encompassing thrombocytopenia, first thing which you need to assess is the risk for bleeding. Is the patient at risk of bleeding? If patient has a platelet of less than 10,000, irrespective if the patient is not actively bleeding, transfusion remains the only treatment available, which can be, if a patient is able to procure a single donor platelet, that would be a preferred one because that would increase the platelets by a good 25 to 30,000 at one go. So that would be a life saving. In case that is not available, then random donor platelet transfusion can also be done. But then the amount of transfusions would vary from 4 to 5, depending on the degree of severity. If platelet is not less than 10,000, but patient is bleeding, then irrespective of the amount, the value of platelet, you again have to go ahead and transfuse. Once you have established that there is no risk of bleeding or bleeding is settled, second thing is find out the cause for thrombocytopenia. Because treating the cause for thrombocytopenia itself corrects the platelets. So cause could be, for example, if a patient is on an antibiotic like linezolid or is on vancomycin, these are the drugs which can cause thrombocytopenia. So you may have to stop this treatment. The patient is having any active viral infection, then you may have to stop the treatment. Patient is a patient for CLD, then you need to correct the primary disease per se. So correction of these primary diseases will reduce the further thrombocytopenia. But this is like, it's a long process because these measures take at least 5 to 7 days to re-establish the levels of platelets towards normalcy. Then there are multiple drugs which are also being used where you feel that you are unable to either establish the cause. For example, if there's ITP, you institute steroids or you give IVIG, the platelets tend to recover. But in situations where you do not find a cause, then there is increasingly a role of usage of certain thrombopoietin analogues or even interleukins have been well researched in this context. And of late, we are using some other alternative herbal preparations also to some modest benefit. So if I can just, tell you more about these interleukins. Interleukins have been FDA approved. They have been established that they can benefit our patients, but the amount of side effects they institute precludes us for its usage in the clinic. So as of now, we are not very comfortable, and most people do not utilize interleukins as a management of platelets. So primarily bleeding risk to be covered by platelet transfusion, address the primary cause. If there is a cause established, if there's an ongoing active oncological treatment which is causing that, you need to interrupt that treatment and subsequently alter your course of treatment by decreasing the intensity of treatment.
And there have been new molecules like thrombocytopin receptor agonists. So, I mean, what are these and can be used?
So, see, thrombopoietin, as you understand, it is a stimulator for platelet formation. Like erythropoietin causes the stimulation of RBCs, thrombopoietin causes the stimulation of platelet formations. It is one substance which is secreted from the liver, and it promotes the platelet stimulation as well as maturation. So, right from I believe 94, 95, there was a lot of research by trying to use thrombopoietin as a promoter for stimulation for platelet production when there is a thrombocytopenia. But somehow studies did not give much benefit, particularly so the first generation thrombopoietin analogs, they tend to produce some antibodies. They were producing antibodies against the platelets, so effectively they were not giving any benefit. But lately we have a couple of analogs. I think one is called Romiplastin, the other is called Ethambutol, commonly we call it Revolade. These are the ones which are now established in the clinics. There are quite a lot of studies also which are showing that they tend to reduce the thrombocytopenia nadir after chemo. They help in reinstating the levels of platelet if we have used them. And still, the problem is that it is approved in a lot of countries, but FDA still hasn't approved them across the globe. And it does not still figure out as a treatment of choice in any guideline. But these are very promising drugs. I personally have a good experience of using these particular drugs in GBM patients who have been on temozolomide, and there have been treatment breaks because of thrombocytopenia. So usage of this particular drug has definitely worked out in reducing the chemotherapy-induced thrombocytopenia and has also helped in reducing the treatment breaks in these patients. Dr. Saurabh? So I believe Dr. Saurabh is going to join us again because of some network issues. So I was just talking about thrombopoietin analogs. So the thrombopoietin analogs, the commonest used drug is Romiplastin. It is used in the dosage of 2 to 3 microgram per kg. So we can give it either as a 250 microgram weekly dosage for 4 weeks, or alternatively, if requirement or the body surface is higher, we can go for 250 micrograms twice weekly for 4 weeks. Romiplastin tends to increase the platelet count by 60% by 2 weeks. So these are not very fast-acting drugs. It's not that just like our GCSF we use for white blood cells, where we give day 1 injection and the very second day the white blood cells shoot up. These drugs take time. They take at least 4 to 5 days, and the maximal benefit comes at 10 to 14 days. And despite that your platelet levels go above 80,000, you continue to use it till you bring it between the range of at least 1 to 1.5 lakhs. So that is one, I think that would be a new kid on the block, which we are looking at as something which could be promising.
Sure. That's insightful. And any other new drugs which we expect to come up for such kind of situations or thrombocytopenia?
So I think the analogs itself are being researched. So each analog, once you get a first generation drug, you try to reform or find more benefits and more equi-efficacious drugs with lesser side effects. So right now, the concern with this particular generation drugs is that we don't have much phase 3 data. And we want to also see, like, if you remember, since you are also from oncology background, erythropoietin backfired. Erythropoietin said that you will not use it in radical patients. It is causing DVT. So only use it in palliative settings. So I think what we're looking at here is more data in Romiplastin and Ethambutol, whether it will be affecting our progression-free survival, or is it impacting the radiation or the chemosensitivity to a particular tumor, or whether it does not predispose patients to a disease progression. I think these are the factors which needs to be first well evaluated. If they don't stand the test of time in these contexts, then we will look for a third generation probably.
I just hope we get some better solutions and more improvement. They still take 10 to 14 days, right, to impact. So if I have a patient for surgery or for a radiation, still it's a long gap. I mean, giving a gap of 2 weeks, I know it does have an impact on the outcome when they have it in a long-term period. So I just hope we get some better options for this. But is there any way to prevent thrombocytopenia? I mean, is it any way that you can prevent thrombocytopenia when you're starting a patient on cancer treatment? Somehow we take some preventive measures to prevent this situation?
So see, whenever you are planning an active oncological treatment in the multimodality clinic, first of all, you need to understand what is the baseline status of the patient. Is the patient already having a borderline platelet level? And then what are the likely treatments patient is likely to go for? For example, if there is a concurrent chemoradiation and you are likely to give radiation to a very wide area of your pelvis, or the bone marrow is going to be exposed to the cytotoxic or the radiation effect, then you need to take certain precautions. So by precautions, first of all, as I told you, like selection of drugs, cisplatin versus carboplatin, maybe you select cisplatin because carboplatin will cause less toxicity, or you're using gemcitabine versus folfirinox, you would prefer folfirinox because gemcitabine causes more thrombocytopenia. So the choice of drugs can be altered where you're anticipating more thrombocytopenia. Secondly, like as a radiation oncologist, we know we have a wide range of radiation techniques. So your choice of technique can be better. Like there are a data set which suggests that whenever you are treating patients with IMRT, intensity modulated radiation therapy, you can reduce the bone marrow dosages, particularly VMAT based techniques. The volume of the bone marrow, if you are able to restrict the volume of bone marrow receiving 10 gray or 20 gray to below 80 to 90%, the chances of the myelotoxicity will decrease. So choose judiciously the treatment so that your patient will be not predisposed to higher side effects of a particular treatment. Then a lot of patients, many times patients say, ma'am, we have seen a lot of dengue patients coming, they drink goat milk, and they take papaya leaf extract, they take whatnot. So I think more than us, the patients are also worried that platelet is something which might interfere with their active treatment. So my take on that is anything, if your counts are fine, you are taking these products, we do not stop you from taking that. But it is your medical management which should be judiciously tailored to that particular patient if there is a higher risk of thrombocytopenia. Especially like where you're treating magna field, you're doing craniospinal irradiation, you're treating very big area of treatment, monitor them closely, do bi-weekly blood tests, and do not wait for the platelet to drop down to below 50,000. At 80,000, if your peripheral smear is showing that there is a fault, I think that is the time you should give a treatment break or introduce a thrombopoietin analog at that particular stage itself.
Right. So, I mean, just a situation out of it, I mean, if you have to give a craniospinal radiation, I know it's a big field and the patient does have a propensity for a thrombocytopenia, maybe an ITP or some other disease. So do you take any specific precautions or any kind of specific protocols that you follow to take care that if I know the patient is going to have such kind of a thing? So are there any interventions that you do?
So vis-a-vis any routine chemoradiation, when you're doing CSI, then we do bi-weekly blood tests where we are anticipating more myelotoxicity. So instead of doing volumes once, blood counts once, we would do twice. Second thing is here again, your techniques like IMRT would be beneficial because you're not, apart from the marrow of the spine, you're able to protect the ribs, you're able to protect the other flat bones, the scapulae. So if you're using a good technology, you again can limit your myelotoxic effect of treatment even in CSI. So I think these two parameters do help. And if you're monitoring them well, you can catch them early. The moment the dip starts, I think that is the time you intervene. And in children though, Thromboplastin, I would say not much experience of using it. And we have been hesitant in using Thromboplastin in children since we do not have the long-term outcomes of these particular drugs in this particular age group.
Sure. I mean, any insights related to Kanika papaya and Tina cordifolia? I mean, these are something which less, but any insights on these? What the role they play?
So as I told you, patients themselves are very conscious. We're living in a generation with the Google enriched knowledge of our patients. And as I told you, the dengue experience, people come with this experience that can we take papaya leaves? So actually the active agent are these two particular agents. So we have been using it. I'll be very, very discreet in telling you. We have been using it because the capsule forms are coming. after the dengue experience of the last 10-15 years of our country, these have formal capsule preparations which have come in, and we have been using it. It is supported by phase 2 data. There have been phase 2 data wherein there have been found significant reduction in platelets. But my clinical experience is it is modest. You cannot expect a 20,000 platelets to jump to 1.5. Yes, where there have been values hovering around 80 to 90,000, consistent use, we see modest effect, but they are not magical or life-changing, but there is a data to support it. I would not say it is not evidence. These evidence have been there in dengue patients as well as chemotherapy-induced thrombocytopenia also. I can recall at least 3 to 4 randomized phase 2 data which have shown benefit of these two agents. So I think more answers would come from what studies are ongoing at IRCH. You might be aware the Ministry of Ayush with the oncology department at IRCH are sitting and establishing the benefit of the allied specialties in oncology management. How these particular drugs can help out in increasing immunity or help out in building resilience in the body of the patient following oncological treatment. So I think more data, but phase 2 data, modest benefit. That is my take on these two particular agents.
And in specific patients, I mean, is it for all kind of thrombocytopenia patients that you have used it, or is like in specific patient does these drugs work from a severity perspective?
So it is, I think the first thing is in severe thrombocytopenia, it would not benefit. It would be just mild thrombocytopenia where I would say it would give some modest benefit. In severe thrombocytopenia, you have to definitely go more radical in terms of transfusion as well as active treatment of the causative agent for the thrombocytopenia.
Okay, I think we had a comprehensive discussion on thrombocytopenia and oncology. Any other points or any other thoughts about the thrombocytopenia and oncology patients that you feel we haven't covered and are critical from a medical or from a medical perspective? If you want to provide those thoughts.
So see, I would share a few clinical, I'll be happy to share a couple of clinical situations where, we always presume that thrombocytopenia happens just because of the treatment we undertake. I have at least 4 to 5 patients where the moment we started our treatment, in the second week itself, the platelets dipped drastically. So sometimes, incidentally, ITP or underlying liver disease has been exposed when patient came in for oncological treatment. So when you're screening your patient, I think it is important when you're screening your patient day 1 for oncological treatment, be very, very careful in evaluating the patients in terms of their drug history, what all medications they have been taking, in terms of what are their previous histories of all the interventions as well as any medications they have been taking. Because then the patient tends to focus on cancer. They tend to focus on malignancy and tend to forget that there are many more things that need to be disclosed to the doctor. So that is of importance. I think one has to be good at time of screening. So your treatment which you have selected day 1 is judicious, rather than then thinking at a hindsight that my choice of drugs is wrong because I did not account for these parameters in this patient. So I think that is one message I would definitely want to give.
Quite critical, I must say. Early interventions always help, and we have seen in our practices that intervening early on does have an impact on the long-term survival as well as the management. Right. So I think it was really great connecting with you, Dr. Kanika. So thanks for all your insights. Thanks to VOH for this platform. So that's all from my side, and I'll let you go back to your OPD and take care of the patients.
Sure. Right. So it was great connecting, and thanks Voice of Health. I think it is an important topic, less talked about, but of importance. Yep. Thank you.
Sure. Thanks a lot. Take care. Have a good day. Thank you.
Bye. Bye.